I would like to start this talk. The title is Testosterone More Than Sex, just dedicating this talk to my mentor. This talk will be in memoriam of Mario Serio, that essentially was my chief, but he was not only my chief, but was one of the founders of the European Academy of Andrology, had been the director of the Department of Clinical Physiopathology and of the Endocrinology unit within, and been the president of the Italian Society of Endocrinology between 1999 and 2001, and been president of the Italian Society of Andrology. And it's difficult to find good work to recall Mario, and Mario is really missing us a lot. Mario generated several children, and some of these children really grow up, as is Gianni Forti here. And in this slide are presented some of the children of Mario Serio that belong to the family of the andrology unit that was founded by Gianni Forti, and now is directed by myself, that changed from andrology to sexual medicine. And in the audience are present several of these scientists, and I would like to thank all the people for the clinical study: Elisa Bandini, Valentina Boddi, Alessandra Fischer, Francesco Lotti, Angela Magini, Edoardo Mannucci, Riccardo Manzani, Matteo Monami, Giulia Rastrelli and Valdoricchia, and the people that did the preclinical study: Paolo Comeglio, Sandra Filippi, Elena Malischi, Anna Maria Morelli, Linda Vignozzi. But in particular, I would like to thank Giovanni Corona, that is seated here, one of my main collaborators, and Gianni Forti, that was my mentor, as I said before. Now, the topic is testosterone more than sex. And it is obvious that for male individuals, sexual activity is very important. I have not to convince about this point. Maybe I have to convince about the fact that sexual dysfunction are a useful symptom because they indeed are tightly related to male hypogonadism. And Fred Wu in the New England Journal of Medicine last year publishing a study involving the European male age study demonstrate that sexual symptoms are the only one that clustered with low testosterone in, at least in the European population. So sexual symptoms are very important. But the paradox is that in my mind, impotenza che fortuna, that means that impotent patients are indeed lucky. Why I think that impotent patients are lucky? They are lucky because having these borrowing symptoms, they do have more occasion for taking care of their sexual, not only, but overall health and life. So they can undergo more to medical examination, therefore improving not only their sexual life, but most importantly, their overall health. Why I'm telling you this story? Because the population that I'm referring to, the population of people with ED, is indeed the population at high cardiovascular risk. And this is an important point considering the result that I will show you this afternoon. Because in fact, ED is, in our mind, a surrogate marker of cardiovascular diseases as hypertension, myocardial infarction, metabolic diseases as obesity, type 2 diabetes, endocrine diseases, everyone knows that hypogonadism is one of these, and psychiatric diseases as depression. So let's start with obesity. All the data present in the literature show that there is a negative relationship between the degree of obesity and testosterone. And I think that in several series, this data have been published a lot of time. These are data from our unit that are data on people with erectile dysfunction. These are 2,500 patients. And as you can see here, there is a clear-cut relationship between increasing class of obesity from lean individual to severe obese individual and a stepwise decline in total testosterone. This decline in total testosterone is associated to a parallel decline in sex hormone binding globulin, and the effect of sex hormone binding globulin does not compensate the fall in testosterone. In fact, free testosterone calculated by available testosterone and calculated free testosterone are decreasing. Also, the important point is that LH level is not increased as a function of obesity. Therefore, this is an hypogonadotropic hypogonadism. So the message is low T is associated with obesity, and I'm not convinced about this point. The second question is obesity associated with cardiovascular risk factors? To answer to this question, I would like to present data on almost 1,700 subjects that have been followed longitudinally in our unit for a mean follow-up of 4.3 years and a total follow-up of 8 years. And we obtain information about measured adverse cardiovascular events, so on their cardiovascular events, using the City of Florence Registry Office. These people at baseline undergo to a series of examination, medical examination, Doppler ultrasound of the penis, and structure interview that we have developed in our unit. The name are SIEDI to test the pathogenic component of erectile dysfunction, and androtest that test the symptoms of hypogonadism. We found that during this follow-up, 8% of the population have measured adverse cardiovascular events, that for the majority of them were ischemic heart disease. And 10% of these were fatal. Now, at baseline, which are the risk factors that are associated with obesity? These are the obvious ones. As hypertension, you can see that the prevalence of hypertension is increasing as a function of obesity. Dyslipidemia, there is a stepwise decrease in HDL cholesterol as a function of obesity. Triglyceride level, there is a stepwise increase in triglyceride as a function of obesity. And glucose abnormality, as shown by glucose level and the prevalence of type 2 diabetes that is increasing as a function of obesity. And obviously also the penile blood flow is decreasing as a function of obesity. So the obvious answer is yes, obesity is associated with cardiovascular risk function. Now we know that obesity is associated with low testosterone, and the question is obesity associated with cardiovascular events? Yes, obesity is associated with the cardiovascular events. More severe is the class of obesity, more events we register during the follow-up. And in particular, overweight is increasing as a hazard ratio of 1.5, and severe obesity is increasing by 2.6. So obesity is increasing the number of cardiovascular events in this particular population. Now, the point is, obesity is associated with low testosterone. Is low testosterone associated with measured adverse cardiovascular events in this particular high-risk population? And the answer was no. We didn't find any significant association between the degree of hypogonadism, defined as below 8 nanomolar or below 10.4 nanomolar, in this particular population that is symptomatic, just because all these people came for sexual dysfunction and measured adverse cardiovascular events. So the message is low T is not associated with measured adverse cardiovascular event in this particular high-risk population. But the next point is low T associated not with event, but with mortality for event, with lethality? And the answer was yes. There is a dramatic association between hypogonadism and mortality for events. And this is the relationship. Having testosterone below 10.4 nanomolar increases the chance of having a lethal event by 6-fold, and having total testosterone below 8 nanomolar increases the chance by 10-fold. And these are the Kaplan-Meier curves that clearly indicate that more deep is the hypogonadism in this particular population, higher is the chance to die for cardiovascular events. And even if you introduce in a Cox regression model as a covariate morbidity index, age, or other confounders, still the association between low testosterone at baseline and the risk of death for cardiovascular mortality is increased by 10-fold. And even increasing the follow-up, as we published last year at 10 years, still you can see here that there is a dramatic difference between those having total testosterone at baseline below 8 nanomolar and higher than 8 nanomolar, while the number of events didn't change. So the message is low T is associated with cardiovascular mortality in people with hypogonadism. Now, this is a particular serious, is patient with erectile dysfunction. What about other serious? Giulia Rastrelli, that is present in this audience, helped Giovanni Corona to do a meta-analysis that had been published this last year in European Journal of Endocrinology on all the studies that are available on the relationship between hypogonadism and cardiovascular mortality in men. They retrieved 71 papers, 54 was from cross-sectional studies, 11 from longitudinal study, and just few, 6 for intervention study. Let's start with the first question. Is low T associated with events? And let's ask the answer to cross-sectional studies. So these are results from cross-sectional studies. And in cross-sectional studies, although there is a large variability, but meta-analyzing all the results, we found that there is a statistically significant association between the presence on non-angiographically documented cardiac events and a decrease in the total testosterone that was around 2 to 3 nanomoles per liter. Similar result for angiographically documented cardiovascular event. And similar results have been obtained also for other cardiovascular diseases. Therefore, the message is that in cross-sectional study, there is an association between low testosterone and cardiovascular event. So low T is associated with MACE. But the point is this association modified by comorbidities? And we did a meta-regression analysis on the data from the cross-sectional study, and we found important information, as the presence of obesity is attenuating the association between low testosterone and cardiovascular event. Similar result was obtained when was analyzed the presence of other factors as type 2 diabetes that was attenuating. The presence of diabetes was attenuating the association between low testosterone and cardiovascular events. This is tantamount to say that the effect was evident in the less sick population. Similar results have been obtained when hypertension was introduced in the model. So comorbidity, obesity, type 2 diabetes, hypertension reduce the association between low T and cardiovascular event. Now we ask the question, is low T associated with incident cardiovascular event? So we use data from longitudinal study. We move from cross-sectional to longitudinal studies. And the result from longitudinal study was similar to the result that we obtained in our series. That is, that low T was not associated with incident cardiovascular event. So I would like to repeat, low T was not associated with increased incidence of cardiovascular event. But the point is low T associated with incident mortality, as we have found in our study? And the answer is yes. Low T is associated with incident overall mortality, and similar results have been published on the same month by Arroyo in the Journal Clinical Endocrinology and Metabolism in a separate, totally independent meta-analysis, and with specific cardiovascular mortality. So the message is low T is associated with increased overall and cardiovascular mortality. This is what we have learned from longitudinal study. But only intervention study can answer to the question if testosterone administration is associated with a decreased mortality in hypogonadal men. And as has been said this afternoon in another session, unfortunately, at the present time, there is no study available having as endpoint cardiovascular event and, in particular, mortality. So no randomized intervention studies are available at the moment. But there are few observational studies. The problem with observational studies is that observational studies that include intervention have a lot of biases in the selection of the patient that could be treated. So, I mean, this kind of study should be carefully evaluated. But let's see what is present in the literature. The first study has been published as an abstract last year at the British Society for Endocrinology by the group of Professor Jones, and as reported before, this was a study on type 2 diabetes, and they found that, as expected, people that have low testosterone and were untreated have a higher mortality than people that was eugonadal. And this is similar to other reports. This was a 6-year follow-up, and therefore the point is that people that have low testosterone and type 2 diabetes have more mortality. But in this abstract, there was also shown that people that was hypogonadal but treated with testosterone have a reduced mortality. In Journal Clinical Endocrinology and Metabolism last week, there was reported another observational study from the group of Avli Matsumoto. The first author was Shores. And this again was a 5-year follow-up on the effect of testosterone replacement therapy on all cause of mortality in a subgroup of hypogonadal men. This was 1,000 hypogonadal men, defined not by symptoms, but just by having very low testosterone that was below 8.7 nanomolar. We don't have the symptoms of this patient. What they found is very similar to the finding of John's group. That means that if you look at this Kaplan-Meier curve, you can easily see that the untreated patient have more event than the treated patient. And the treated patient, after 5 years, have 10% of event, the untreated the double. And even after adjusting in a Cox regression model for confounders, still the difference between treated and untreated subject was highly statistically significant. In particular, what we did is with Giovanni last week, we meta-analyzed the two studies, we put the two studies together, and as you can see, these are the data from the Jones, from the British, these are the American one, and as you can see, having no treatment would increase by a factor of 2 the chance of mortality. But these are observational studies, and again, cautiousness is needed in evaluating this result because there is a huge selection bias at the beginning. I mean, the doctor could choose to treat more healthy subjects than more sick subjects, and this could prevent the result. So cautiousness on the interpretation of this data, but the data that we do have is that not treating hypogonadal patient double the risk of overall mortality in subjects with low T. How could be explained the relationship between low T and death? One explanation is low T is inducing frailty. More falls, more low bone mineral density, more fractures. Or can be through the reverse, that the underlying diseases could be associated with low T. That is very, very similar. So low T is just an epiphenomenon of an underlying disease. Low T have the same value that low T3. But the question that we were asking is obesity modulating the low T associated cardiovascular risk? Just looking at the data that I presented before from a meta-regression analysis, I said that the presence of obesity was associated to a decrease fall in testosterone in patient hypogonadal. And with Giovanni, we did a cross-sectional study on 2,200 subjects with ED, dividing the population, stratifying the population according to the presence of obesity or not. And what we found that a lean individual defined as BMI below 30 kilograms per square meters, there is a clear-cut association between quartiles of cardiovascular risk as estimated by Progetto Cuore, that is an engine available for Italian population, and testosterone level. So in people with low BMI, low T is associated with an increased estimated cardiovascular risk. But in obese subjects, we could not find this association. The association was not statistically significant. So it was through this association only for lean individuals. Therefore, we decided to investigate longitudinally if analyzing the data that I presented before by splitting for BMI, we could observe differences in cardiovascular risk between obese and lean individuals. This slide shows for the data on the prevalence of hypogonadism according to BMI and age, for quartile of age. As you can see, lean individual, as a factor of age, the prevalence of hypogonadism in this particular population is increasing. A similar increase was evident also for overweight individuals, but was not present for obese individuals that already reach the high percentage of hypogonadism at a very early age. Now, when we look at the again, at the prevalence of events in this particular population, we found that, in fact, the lean individual having hypogonadism is associated with an increased cardiovascular risk. That was statistically significant. This relationship was null lost its effect in overweight individual and change, and was the reverse in obese individual, although was not statistically significant. However, when we look at the relative risk of obesity, hypogonadism for cardiovascular disease, we see that BMI per se would increase the risk. Low testosterone per se was slightly increasing the risk, but the important point is that the interaction term, that means the simultaneous presence of obesity and hypogonadism, was protective. So if you are obese and hypogonadal, you are protected from the risk of having cardiovascular disease. And this is more clear in this other cartoon that show in hypogonadal subject, this is just in hypogonadal subject, the effect of increasing class of BMI. As you can see, having obesity is a protective factor in hypogonadism, is a protective factor for cardiovascular diseases. And this is evident also just analyzing a very useful clinical point, that is testis volume. People that was obese without events have lower testis volume than people that was obese with events. And this was statistically significant. So there is a very complex relationship between obesity, hypogonadism, and measured adverse cardiovascular event. And obviously the point is testosterone a suitable therapy for obesity-associated hypogonadism? And we have to ask for intervention studies. Intervention studies have been done in different patient populations. There was and meta-analyzed in different meta-analyses. The first meta-analysis was published by Andrea Isidori 7 years ago, on late onset hypogonadism, and 2 meta-analyses have been published by our group last year. Let's see the data on late onset hypogonadism. This is referred to 1,000 subjects in a 29 RCT study for an average short treatment that is not 9 months. What Andrea found is that intervention with TRT in hypogonadal subject was associated with a reduction of total fat mass. In addition, he found that treatment with testosterone was associated with an increase in fat-free mass, so in lean mass. He found that there was a statistically significant effect of treatment with testosterone on total cholesterol, and a mild effect on HDL cholesterol. Let's move to other patient population, that is diabetes-associated hypogonadism. Unfortunately, there are only few studies that could be meta-analyzed, and we did this meta-analysis in 2011. Therefore, before having the ×2 study published, but we obtained from Professor Jones the data, so we could use the data before the paper was published. But having also the ×2 within the number of patients that was meta-analyzed was 228 for 32 weeks, so a short follow-up, a low number of studies, but this meta-analysis showed that, in fact, treatment patient with type 2 diabetes and hypogonadism was associated with almost 1 point reduction in glycosylated hemoglobin, a significant reduction in fasting glycemia, a significant reduction in triglyceride level, and significant reduction in fat mass. What about metabolic syndrome-associated hypogonadism? We meta-analyzed last year all the data available, and again, there are few studies, only 300 patients followed up for 58 weeks. But even in this subgroup of patients, we found that treating with testosterone was associated with a reduction in fasting glycemia, a reduction in HOMA index, we are in the metabolic syndrome story, a reduction in triglyceride, and a reduction of 5 points in waist. 5 points of waist. a small reduction, a small increase in HDL cholesterol. Now I would like to show you, I think for the first time, data from a study that was not placebo-controlled, but was a study that was very similar to our daily practice. This was an international multi-center post-authorization surveillance study. The first author is Michael Zitzman. The endpoint was to assess the safety and effectiveness of an injectable long-acting testosterone endocannabinoid in hypogonadal men in daily clinical practice. This study was involved 1,500 patients enrolled in 150 different sites in 23 countries worldwide. 78% of the patients was the continuation rate. The mean observational period was 9.2 months. And patients were treated with testosterone endocannabinoid for an average of 9.3 months. The point that I would like to show you is that in subjects that received no previous treatment with testosterone, even in this study, there was a 5-point reduction in waist as from the meta-analysis. And a reduction in waist was evident also in subjects that have been previously treated with other preparation of testosterone, even though the reduction was smaller, was 3 points. And not only waist was decreased in the EPA study, but there was a statistically significant decrease in blood pressure, mostly in the systolic pressure, in triglyceride, total cholesterol, and LDL cholesterol. Therefore, this interventional study related to body composition indicate that testosterone seems a good therapy for obesity and metabolic syndrome associated hypogonadism. But the point is, which is the mechanism of action of testosterone in visceral fat? It's not easy to understand. To tell you what we have learned this from an animal model. We induced in the rabbit a phenotype that was very, very similar to the human metabolic syndrome. And we have published several papers on this topic that I have not the time to go over. But I would like this afternoon just to tell you the result of one of my PhD in my lab, Elena Maneschi, that work on this topic together with the other people that I mentioned before. And I help on this study also from Roberto Vettor from the University of Padua and from our gastroenterology unit. As I said, the high-fat diet was inducing all the stigmata of metabolic syndrome, hyperglycemia, reduced glucose tolerance, hypercholesterolemia, hypertriglyceridemia, hypertension, increased visceral fat mass, and, very important, hypogonadotropic hypogonadism. A subgroup of this animal have been treated with testosterone, 30 milligram per kilogram per week, and these are the results on visceral fat. This is the increase in visceral fat in high-fat diet animals, the animals with the metabolic syndrome, and this with testosterone. Giving testosterone was abolishing the presence of visceral fat in the abdomen. And if you plot the quartile of delta testosterone, that is the increase in testosterone in these animals versus the visceral fat weight, you can see that higher the testosterone, lower the fat weight. And higher the increase in estradiol, higher is the increase in fat weight. Therefore, there was an inverse relationship between testosterone and weight and estradiol and weight. And the same relationship is present in morphometric study, going to look for the diameter of the adipocyte. The diameter of adipocyte was increased by high-fat diet and totally restored by testosterone. And testosterone was able to reverse the increase of some protein that is very important to the handling of triglyceride level, of droplets of triglyceride level as perilipin. And when we look at the apoptosis, we found that apoptosis in the visceral fat was reduced and restored by testosterone. Now, another point is that GLUT4 is the translocation to the membrane of GLUT4 was reduced by the diet, by the metabolic syndrome, and treating with testosterone was restoring GLUT4 in the membrane. And we found a very nice association in the visceral fat, in the homogeneity of visceral fat between the expression of the androgen receptor and GLUT4. Another association that we found was between the expression of androgen receptor and important androgen-dependent gene, STAMP2, that is important also for sensitizing to insulin in adipocyte. And very interesting, the knockout of STAMP in mice induces a picture that was very, very similar to metabolic syndrome. And the recent paper published in JCM demonstrated that more obese and more diabetes, less STAMP2 you have in visceral fat. Now, STAMP2 was dramatically dependent on delta testosterone and was increased in this animal by treating with testosterone. All the gene that was controlling adipogenesis was associated, their expression was associated with the androgen receptor. This is FABP4, CABP alpha, lipoprotein lipase, ROC2, and very important, adiponectin. Adiponectin in this animal was dramatically dependent between the ratio on delta testosterone to delta estradiol. And the reverse was for inflammation. Genes that are important for inflammation as TLR, this is TLR4 and TLR2, are decreased by increasing the delta testosterone, delta estradiol level. Now, to understand well what was going on, we, from this different group of animals, control metabolic syndrome and metabolic syndrome treated with testosterone, we put in culture we isolated the preadipocyte, and we put in culture the preadipocyte, treating or not with the differentiation mixture that is insulin, dexamethasone, and isobutylmethylxanthine for 10 days. We are not treating in vitro with testosterone. These are the animals these are the tissue that are coming from animal that was hypogonadal or treated with testosterone. And what we found is that in the high-fat diet, adipogenesis was impaired and totally restored by testosterone. And when we look at the number of positive cells for adipored, we found that, in fact, they could not stimulate adipogenesis, but testosterone was restoring. And let's look at the confocal microscopy. Just look at this image. This is a control animal before and after induction of adipocyte, and these are the size of the droplets of fat. Just give a look what they look in the diet animal with the metabolic syndrome and what is the effect of testosterone. That is fantastic. And was, in fact, highly statistically significant. So testosterone was restoring the ability to sensitize, to handle the triglyceride in this animal. And in fact, when we look at the glucose uptake in this differentiated adipocyte, we found that there was insulin resistant that was totally restored by treating with in vivo, treating with testosterone, not in vitro, in vivo treating with testosterone. And all the genes that were important for adipogenesis were downregulated by high-fat diet and restored by testosterone, including STAMP2 and ERS1. Now, the final point, this is my last slide, is on the translocation of GLUT4 to the membranes. Also, confocal microscopy demonstrate that treating in vivo with testosterone and culturing the adipocyte will restore GLUT4 translocation. So in our mind, the mechanism of action of testosterone in visceral fat is increasing insulin sensitivity, first point, and restoring high-fat diet deranged adipogenesis. So these are my final message, that is testosterone on the sex, yes. Testosterone might exert multiple beneficial effects on male hypogonadism, but the clinical study we do have are very limited, and we need urgent, large randomized double-blind placebo-controlled trials with testosterone replacement therapy to understand the effect of this important male hormone on adipogenesis and cardiovascular risk. Thank you for your attention.